well, I've got my friends with me and great colleague Cheryl Granger with me. And I've also got Victoria Rixon, who you may know as the Honest Midwife. But before I bring them in to say hello, I just want to add, and I've been given permission to say this, that between us, Cheryl, I, and Victoria have 11 children between us. So a football team, right? So we know a bit about babies and having babies. So I'm not going to waste any more time because we've got so much to cover. And I know that we're not going to be able to cover everything, but let's get cracking. So welcome, Cheryl, to UK Column. Thank you so much because you've been doing so much work on the pregnancy data with the MHRA. And predominantly, that's why you're here to speak to Victoria this afternoon. So welcome again, Cheryl.
Hi, everybody. Hello, Debbie. Thanks for having me.
And right, let's get straight to it. Victoria Rixon, the Honest Midwife, who has now left the NHS and is going to tell us what life in the NHS is like. But before we do, my first question, Victoria, is, Victoria, welcome. And what is a midwife?
Hi, Debbie and Cheryl. Thank you so much for having me. Well, what is a midwife? Big question, isn't it? But, I trained as a midwife at university. What I thought was a midwife when I was a mother was completely different to what I became. And I think anything goes without saying that midwives are there and there for women and their protection and their advocacy. So to be a trained, skilled midwife was really an honour for me. I was very, very excited to be part of the journey and, to learn really the depths of what it was like to be that. When we all say, oh, I'm a midwife, everybody always says, oh my God, I love that job. Tell me about that job. It must be wonderful. And it is wonderful, but there is such another side to it. So from a woman's perspective, when I needed a midwife, she was really, really there back in, the years when I had my children. And midwifery now is a completely different profession than it was even 10 years ago.
And that's what I want to say too, because I went into general nursing. I'm not a midwife. I went into general nursing for the love of the job, for the vocation. And I did a little bit of midwifery during that training, and it's joyful and it's celebratory. It was amazing. So, Victoria, such an incredible job. We need midwives so desperately. Why leave?
Yeah, really sad time. Safety, that's your biggest part of your code of conduct, is to keep people safe, to make sure that you're keeping yourself safe in your practice, you're keeping up to date with all of your educational needs, learning objectives, reflection. So all of the things that I adhered to in my 3-year yearly validation were all, tickety-boo. But actually it was incredibly unsafe. My last shift was with only 2 midwives, 3 midwives. I think someone came down, if I remember rightly, but it was 2 of us predominantly. And it had been on and off like that for a few months, and it really had started to burn me out. And it was unsustainable. And I think the safety element is well known to the public. We talk about it a lot, but actually what we don't do is we don't talk about it from a midwife's perspective. Women talk about it from their perspective, and that's very well documented over mainstream news and media. But actually, as a midwife, the safety element is incredibly scary. So safety, lack of transparency. You're not able to tell women that it's busy. You're not able to safeguard them and let them know that they might be in for 10 days because we have no staff for inductions. That were, I think, at our highest, we had about 13 waiting inductions with a full board downstairs on labour ward, and you weren't allowed to say to them, we're short staffed. So there was a lot of transparency issues in the communication. Lack of equipment, that's a common thing. Lack of staffing, lack of being heard. So if you hear women come back with their voice through PALs or litigation, but when do midwives really get to voice their concerns of safety? And when they do, it goes nowhere. So we all end up not answering to the monkey surveys or the staff surveys, and they send out these yearly staff surveys. And every year on year, you get less and less. And maternity were apparently one of the worst uptake of figures. So it was almost like midwife have just given up. We're so tired. And there's no change coming. It's actually getting worse. Not to mention the increase in harm. I actually could no longer cope with the baby losses, the mummy harm, the harms to mothers. I couldn't actually sustain having to process each shift. It became a pile, like a motorway pile up eventually, that I wasn't sleeping. I was having, really awful thoughts. I was, worried about litigation. It was absolutely enormous. And, one little me against a whole system like that it was just overbearing, and it was just too much to carry. And in the end, I went.
I think there's an awful lot there to unpack, and I know that Cheryl is dying to come in and ask you a question there. But before she does, I just want to make a comment there that you mentioned. There's a lot more inductions. And back in my day, in 1983, when I had my daughter, I was in for 8 days, and it was a normal delivery. And inductions, they weren't that. We didn't hear too much about them, and even less about cesareans. So we'll come back to that a little bit later on, if we may. But in the meantime, Cheryl, do you want to jump in?
We mentioned when we talked before about this birth rate plus, and if you look that up, it actually says it's supporting safe staffing in the maternity workforce. So they're supposedly supposed to be collecting the data that you're producing in terms of what the staff levels should be. So when you're saying when you left, you had 2 people looking after the ladies who were in labour. How many people were you looking after at that point? I believe there were people on the ward waiting to come to you.
On my actual shift, the last shift that I went on, I actually remember getting out of the car and walking down to labour ward, and I felt like I was shrinking as I got to the door. It was like, I'm 5'7", but I was really shrinking as I went in. I was really petrified and dreading it. And when I got in there was a very busy board, and I looked at my manager, and I remember her shutting the door to do handover, and there was only 3 of us, including her, in that room. It was frightening. The cesarean sections, electives were going on. Not only did you have that, you had women on the ward. So I had a lady in one room, another lady in another room, and another lady in another room. And it was myself, and I was actually looking after a student that wasn't my student. She was somebody else's, but her mentor wasn't in. And it just felt so, it was suffocating is the word, suffocating. I couldn't cope any longer. It was horrific. Triage was absolutely heaving. And not only that, it was the impending doom that any minute something was going to go wrong. And there was no leniency for error at that point. Where's the room for the error? You couldn't stretch anymore. So although we're pulling staff out of offices, which is really unfair at times, they have their own deadlines to do. When they arrive to us, they're coming, with a bit of a hostile attitude. They just don't want to be there. And a lot of them have gone out of midwifery to go into admin roles to probably escape some of it. I understand. I kind of empathise with that in a way. But by the time, the shift ended that day, that was predominantly the shift that ended my career. And that had the staffing levels like that had gone on particularly bad on labour ward for quite a few months. It was never historically that bad. The wards used to get starved of staff, and labour ward was always the acute setting. They call it like a mini A&E labour ward. It is a very acute skilled area. So predominantly the staff would then filter to labour ward, but then they had errors on the ward, so they then had to fully staff that, and it just felt like a yo-yo effect. You just felt like you could never go anywhere to be fully the midwife you wanted to be.
So the birth rate plus is not working, is it? Because it's always going to be behind what's happening, even if they're given proper information. And even if the birth rate's going down, you've still got more complex births coming to the fore by what you've said. And that obviously means that takes more of your time. You need more skilled people there. The student nurses are not learning from any normal situation. Can you tell us a little bit about your opinion on what I've just said?
Yeah, so the birth rate plus, when I actually looked into it, when it was very highlighted a lot during continuity of carer, I remember thinking it didn't look very well evidence based. But I'm not the most intelligent person when it comes to understanding evidence. I think there is a very skilled person that can fully pick apart evidence. You know, if you've got people that love research and number crunching, great, but that is not my forte. But I just remember thinking it didn't look reliable. So the birth rate plus, as you've already said, is based on your live births. It doesn't actually equate to your women that stay for a period of time, a duration, a length of stay. So you're not even looking at that in a number sense. So if you've got births the year before at 5,000 and the next year you've got births at 1,300, you're going by the previous year's birth to staff, but you're not then including the fact that women are actually more complicated and have longer length of stays in hospital, which is why we've got to the place we have with being bed blocked. So it doesn't work. It doesn't fit.
You were talking there about labour ward being as intensive as A&E, and it absolutely is. And if you've got women in established labour, you're going to need a midwife pretty close, right? So you're saying that you've got more complicated births, less trained midwives, more students, not even those that are allocated to you. And this is actually, it's worrying, isn't it, when it's somewhere like labour ward where you need such intensive care. But I was shocked when we were speaking before, prior to the interview, about complex births and cesareans. And could you tell our audience what happens if a woman comes to you and says, you know what, I'm going on holiday and I need to have a cesarean? What's your response?
It's a hard one now. I would have said pre-Donna Ockington's report for that was released in 2020, 2021, that I would have encouraged a woman to feel empowered to make the right decision for her and her baby based on her health, as well as making it suitable for her lifestyle. I'm actually very good. I don't tend to get wrapped up in my own opinion on it. I feel that women choose the birth they want. It's already written there for them. But when you've got to a point where cesarean section rates are now astronomically high, to the point that we are, seeing women walk around with cesarean section scars on their uterus, and we're thinking that's normal. That is not normal. So whilst I am a huge advocate for emergency cesarean section in labour when it's needed, I think it's a huge concern when we're allowing women to not be educated fully and understand why they've got to that place. And I think birth, when it's around time, can be something in yourself that potentially might be that you have issues about being out of control. And women, when they're pregnant, often feel very vulnerable. Lots of them, they are vulnerable. They're feeling very unsure. They don't know what's coming. And it's actually sitting in your power and understanding that everything's going to be safe and everything's going to be okay, even when you can't see the outcome. So I worry that we're not really and fully understanding women's decision making and how they've got to that. And I think the spread of information that women can just choose a cesarean section is very and deeply concerning. There's lots of reasons why babies are meant to be born vaginally, and we didn't just have a hatch on our bellies to pull a baby out. You have to think about that. So I would probably say to a woman, myself now, knowing what I do, is I would want to work with her one-on-one on that, just that topic alone. And that probably would cover a few sessions of confidence building and having a connection to her body, but we just don't have that space.
Connections to bodies and touch, that segued very nicely, actually, because, going back very quickly to cesareans, I'm noticing with the younger generation, I'm a granny, but with the younger generation, there do seem to be more cesareans going on. And in my day, back in my day, a cesarean it would only be an emergency that we would see a cesarean, and probably they would be in for 10 days, 2 weeks, they would be in hospital. And I'm seeing young mums going into hospital on a Monday, having their baby by cesarean section in the evening, and being discharged the following day, which I find quite alarming. This is serious abdominal surgery. You're not meant to lift for quite a few weeks after abdominal surgery like that, and yet you're going to have a baby to lift and carry. So, it's big surgery, and I think it's something that needs to be considered. But whilst I'm on that subject, I was interviewing the most amazing Jane Dean, who was a midwife trained in the 1960s, who used the Pinard stethoscope to listen to baby in uterus. And she was saying that why would midwives rely on machines these days when they need to touch patients? They need to speak to patients. We need that physical contact. And I know that while we were talking about this prior to this interview, you were talking about how you speak to people, how to pregnant women as they're making their choices on how their journey is going to be. And you were talking about what happens when women present with preeclampsia. And that's another reason that I've actually invited Cheryl to join us today, because I was quite alarmed to hear what kind of drugs are being used for blood pressure, and Cheryl will be able to elaborate on that more. But also I was interested that you said you used a good old-fashioned sphygmomanometer and a stethoscope. Remember those big boxes and the stethoscope and the cuff that you'd blow up the arm, and the nurse would have the stethoscope, or the doctor would have the stethoscope in their ears with it on your arm? You do that for pregnant women, and the reason I found very interesting. Do you want to elaborate a little bit more about the triage, the preeclampsia, the blood pressure checks, etc., that you have to do with pregnant women?
Yeah, so obviously preeclampsia is a serious complication of pregnancy. We don't fully understand why it happens, but it mainly happens to first-time mums. I have seen many women, particularly before I left, there was a lady that had severe preeclampsia in her second pregnancy. So we have to ensure that we're looking out for those risks in women. So a lot of women that have high risk factors are on aspirin. So you're looking for the signs, the vital signs, the visual disturbances, the swelling, the edematous to the ankles, hands, feet, face, that sort of thing. And we have to, as a midwife, use touch. So whilst in nursing, you might put a SATS probe on the finger, and you're measuring the heart rate. As a midwife, you are taught hand on pulse. You can't pick up things like ectopic beats or things like that through these machines. It's through touch. So we use that. We use a we don't use an electronic blood pressure monitoring cuff. It has to be manual. So you have to listen out for those blood pressure readings. Takes a long time when you're a student to really understand and get to grips with all of that. So they're not reliable if they're electronic. We are told that it has to be used on a manual. Strangely enough, when they're in HDU or high dependency or we call them different wards. If a woman has anything significant, she needs to go in a room with a one-on-one midwife and have hourly obs or 15-minute obs. They use electronic from theatre. It's peculiar. So I'm not used to that. I would take it off and put one on her arm, and I'd be doing a second reading. So that was that. And then we use labetalol as a first line defense for preeclampsia, and nifedipine. Now, interestingly, when I was at university doing my drug module, which was in my second year, we had to do a drug calculation, which was 100%. And we had to do a drug presentation to the rest of the cohort. And we all had to pick one drug. So in maternity, you only have a list of midwives exemption drugs and PGD drugs. So you use a certain range. So it's not hard to work around learning them, because there's not as many as nursing. It's a huge generic list, isn't it, for the general public? But for maternity and midwives, it's not. There's a lot of medicines that aren't ethically trialed, so they can't be used on pregnant women. However, the labetalol I picked at university, and I had to stand up and do this presentation to the rest of the class, and you're graded on your presentation and the evidence that you find and the background. Now, because we're all different speakers, different listeners, we might visually learn something more. I don't remember taking much from everybody else's presentation because I was quite overwhelmed with nerves that day, and we had to sit and listen to, I think it was about 20 people's presentations. And we all know presentations can be dull and boring and intense. So when I qualified as a midwife, I never actually really knew much about a lot of these drugs. Yes, when I was at work, I would tick it off my list. And because the universities put you into a strict plan of your training, you don't have a lot of time to do wider reading because you're either working on a day and then going to uni, or you've got an exam and you're just exhausted. So do I know all the side effects of every drug? No. Do I know how to administer them? Yes. Do I know the route to administer them? Yes. But do I know everything about that drug and all of them? Absolutely not.
You explained to us that the drug that you presented as part of your course was the one that you tend to use. So that is the one that you're familiar with, not necessarily every bit about it, but the fact that you know something about it. And instead of having a drug module as part of your course where you learnt about all the different things that are permissible in pregnancy, and to weigh up the pros and cons and all the rest, you kind of stick to the one that you're familiar with, which is understandable. So if you look up labetalol on the BNF, it's basically saying that it's not known to be harmful, except possibly in the first trimester. If labetalol is used close to delivery, infants should be monitored for signs of alpha blockade. So again, with hypertension problems. So it's telling you that there can be problems. And I don't know how much importance is given to looking out for these things. And for breastfeeding, infants should be monitored as there is a risk of possible toxicity, again, due to the alpha blockade in addition to beta blockade that you can get with these treatments. So that's the labetalol. And apparently nifedipine is the other one that does tend to get used in pregnancy. And it's used to inhibit labour. That's one of its uses in pregnancy. And the manufacturer advises that you must avoid before week 20, but risk to fetus should be balanced against risk of uncontrolled maternal hypertension. So it depends how qualified you are to actually work that out. And then it's a lot of pressure on yourself if you're administering these drugs to actually use the right thing. And it says use if only other treatment options are not indicated or have failed.
Yeah, Cheryl. So labetalol, when I actually reflect back now, I don't ever remember looking at the full side effects. I was just trying to understand the drug more in a sense of how it's used in maternity. That's what I can remember when I look back. But actually, labetalol has a side effect as heart failure and, liver complications. Now, preeclampsia can lead to potentially something called HELP syndrome, which is where your liver enzymes go off. You've got proteinuria. You're very, very poorly. So when you think about a drug, and I think about this now, if a woman is on nifedipine or labetalol and she has one of these problems, now nifedipine is a calcium beta blocker, and labour needs calcium as a whole cycle to be able to labour, and that actually inhibits the cells entering the uterus to enable it to contract. So if you think you've got a preeclamptic lady who's severely unwell, but she's on labetalol, nifedipine, and we're trying to induce her now, nifedipine actually causes edema to feet and ankles. So if I've got a lady on nifedipine on the ward and she's got no other symptoms other than proteinuria and hypertension, so she's got protein in her urine and she's got raised blood pressure, and all of a sudden she develops swollen ankles, how do I know it's not the drug rather than the preeclampsia? How do you know? Like when I look back now, I never had the chance because it was so busy to really utilize all of these collective variables to come to a safe medical diagnosis. And it is my duty as a Band 6 to diagnose and escalate to the team and to the doctor. So if you now got a woman with vaccine potentially with a vaccine injury, who's now taken labetalol, which increases heart failure, we're in really sticky waters.
With the nifedipine, it also says the amount is too small to be harmful if you're breastfeeding, but the manufacturers advise to avoid it. So it's always, it might do, it could do. We haven't got the studies on that, etc. when we come to pregnancy, which has been carried out with the vaccines as well. We're not sure. And, there's always a precaution, isn't there, that it's best until you know not to actually use these things. And of course, the problem that you've been telling us about is the experience that students get. So when you're learning on the job, how much are they put into an emergency situation in a lot of cases? And therefore, it's very difficult to gradually get the skills that you need to actually help the pregnant woman.
Yeah, the student journey now is vastly different from when I was training. When I was training, you did blocks with the same mentor in each area. I don't know what they do now, because you become so detached from it that you don't actually fully understand that they change everything so frequently. You can't keep up with the system. It's strange. You can't keep up with what's going on. So when I was a student, the births were different. You had more lower risk women then, so you were able to get your numbers. But now we're in a situation where, students are coming in. There are different caliber of students now. We've lost the bursary, I feel. So the attitude of students is different. I don't know if it's just we all have different generations, perhaps. But I find some students might say, "Oh, that's beneath me, that role," or there's not a lot of respect I've seen from some of the students to their mentors, and likewise the other way. I think we're very poor at failing students if they're not coping, but I don't like fail to failure. I think it's all about communication. Behind anybody not coping is something that's not been fully understood. So there's a discrepancy somewhere in someone's expectation. But for me, I think the worrying thing is, when I was a band 5, I'd only been a band 5, I think, for about 4 or 5 months, and I got an email saying you need to have a student. Now, as a band 5, I had only been practicing in community for 6 months. I hadn't even been on labour ward yet, which meant that when I went to labour ward, I wouldn't be able to deliver my own babies because the student had to get them for the numbers. So if I had rotated into the hospital first and not to the community on my preceptorship programme, I probably would have been robbed of all my births if I didn't put my hand up and say, I'm not having students, I don't feel safe. Now, to consolidate your practice, I would say it took me about 4 years to stop having an adrenaline stress response when I delivered a baby. I would shake because it still felt new, and it still felt very, very worrying that you are in the hands of 2 people. And until you develop that art, it becomes natural because you've done so many. You will never achieve that if you have a student, at least within the first few years of your journey into midwifery. So not only were these students being trained by people who just come onto the register and hadn't even had an awareness of the system, they hadn't even revalidated once or had 3 paychecks. They had students that they had to grade, they had to give feedback on, and it's just alarming. So I actually said no. I said, I'm not doing it. And I put my foot down. Obviously, it didn't go down well. But then what was concerning with the students is if students now are struggling to get their births, and it was a bit like that back when I was training, but it's not as bad. They've got to get 40 births with placenta, and it has to be 40 normal births. So it can't be a ventouse or an elective or a forceps. It has to be delivered by you, and it has to be all done by you and the placenta. Now, what we're finding is because the students are dealing with a lot of high risk and there's not as many low risk births, if a woman attends and she's having a baby and a student needs a birth, then I've seen the managers give the birth to the student and just get her in that room just as the woman's about to deliver. So it's like, do you want to come and catch a baby? And I feel women don't women are aware of what's going on in labour. We've been there ourselves, haven't we? We know, we can hear, we can remember, but we aren't fully aware of the full surroundings. We can remember snippets of what's going on. So although women can consent, I don't believe they would want to consent in that situation. If you put it to them in community at their birth chat, how do you feel if a woman midwife was looking after your whole labour, and then right at the end a student slipped in that you'd never met in your life and delivered your baby? I don't think many women would want that. I genuinely don't. I know I wouldn't as a woman. So I feel like we're just not being transparent across the board. And the problem there is, we haven't got well women. So we've got lots of women that we class as red and blue. Blue is normal, low risk, red is high risk. So if you've got lots of high risk, these students are really struggling to get their 40. So I've got one midwife who's qualified, and she qualified in August. She still hasn't got all of her births. So she's got to come in, and I then wonder, is she paid? Is she insured? You don't know all the legalities around that, because if she's qualified, how can she still, do you know what I mean? There's lots of questions I don't know these answers to, but we just assume it's okay. So I worry about how the students are being trained in terms of that is not safe practice. You don't really know anything about the woman apart from being told, deliver this baby. And the student might not want to do that, but feels obliged because she has to get her numbers. So there's a lot going on there to unpick again.
Yeah. Can I just say that if you have got 20 births that you attend for the whole time and you catch the baby when it comes out, then that is probably so much more worthwhile than just being there at 40 at the end to take the baby when it arrives. Because obviously it's going to continue that we're going to have these births that aren't as easy as they were in the past. And therefore, perhaps this number of 40 is a ridiculous way of actually assessing people. This needs to change, I'd suggest. The complications, we've talked about high blood pressure. You've talked to me about the calcified placentas that you've seen, and obviously there are baby deaths as well. Do you want to say something about if that's changed over recent years, or whether this has been a gradual increase, or what things you are seeing in terms of the complications?
I think even when I did my volunteering in 2012, I remember it being busy. It's always been busy, maternity. But I can remember a midwife was crying in the cupboard when I went in on a Sunday. I left my children at home with my husband, and I went in and volunteered every Sunday on transitional care. And the midwife was crying in the cupboard, and she said to me, "Whatever you do, don't become a midwife." And I never really thought about that until the last year. And I thought, gosh, when I think about that, what was she feeling? I understand what she was feeling. So maternity's always been a bit chaotic. It's a bit of a big cattle and a run for all. It's absolutely pandemonium sometimes. And although there's structure in what we do through our practices and code of conducts and things, when you actually put all of that evidence to that practice, they don't match up sometimes. It doesn't make logical sense. So over the years, like when I was training, like I say, yes, I did see loss, and yes, I did see harm, and yes, I did see shoulder dystocias, and which is where the baby's shoulder gets lodged underneath the pubic arch, and it's a horrendous emergency, and it cost a midwife her role. She left not long after one. It was awful. So you try to not desensitize yourself, and that's something I've been really proud of. I will cry and I will talk about it. However, in the last few years, although I've had a lot of sickness because of my type 1 diabetes diagnosis in 2019, I blamed myself and thought it was my health that was impacting my midwifery. I thought, I can't, I'm not a good enough midwife now because I've got diabetes. And actually what I failed to realize was, and I've only really reflected on this again because I've left and I'm able to look back, is that the system is probably the worst it's ever been in since I've been there in 10 years. And I don't know whether it's very multifaceted. You can't just pick one thing and say it's that. It's a lot of things. And I do think the system is built that way so you never quite work it out. And when you're a critical thinker, and I have to say, I feel like the worst thing they ever did was employing critical thinkers, because we will analyze and we will pick things apart. And it's not difficult to start seeing trends, and it's not difficult to start going, aha, a eureka moment. And then your brain starts, you sit in a daydream and like you're in Alice in Wonderland, you're like, what is going on? So, but because I'm very inquisitive and nosy, I started probing into other things around maternity, into the general side of the hospital. I think what alarmed me last year, 2023, particularly into last year, was how unwell women have become and how many babies had died. And what I kept saying to the bereavement midwives is, surely our birth rate, our stillbirth rate's gone up. It feels like every week we've had a loss, or every few days you were hearing another loss, or particularly around about the in the second trimester alone, I would say more so. And I was delivering women, and normally their placenta would match the size of the baby. You get used to visually seeing, oh, that's a normal placenta. You know, you'd get a good 8-pound baby and you'd look at the placenta and you go, oh, that's a good size placenta. It looks all normal. But what I was seeing was that some babies were large and their placentas were smaller, or their placentas were calcified. And normally you might see that with smoking or heavy drug addiction, or sometimes obesity with placental flow. But it just didn't seem to add up. I was seeing more and more and more of it. And because I didn't quite twig what was going on, I just discarded it and thought, well, there you go, a calcified placenta. But I think what I was finding hard was the amount of loss that was coming in, the amount of, like, I've gone all goosebumpy just saying this, the women screaming, not just through birth, but through loss, will remain with me forever. It will never, ever leave me. And it will never leave them. And they'll remember you just as much as you remember them, because they're locked in that moment. And I think, look, I'm actually shaking talking about it because it's so deeply distressing to, so sorry, to remember that the maternity services that I went into is an absolute dark tunnel of what it is now. So the loss, I worry, was potentially down to the vaccine injuries. I would never say I was an anti-vaxxer. I had 2 vaccines myself. But I think what concerned me was that every time I asked a woman if she'd had all the vaccines, I did not meet a single woman that didn't have a COVID vaccine. And that was alarming, really. They've all had them, they all invested. And, when I didn't really look at the evidence at all until recently, in the last 6 months, about it, but I knew something wasn't right and I could see it. So I've received quite a lot of messages on X and on other platforms saying, look, Victoria, the evidence about COVID is this and this and this. I'm not disputing that. What I am saying is I'm a midwife and I've walked those wards and I have seen those women and those babies. And the common denominator for these women is a COVID vaccine. And that's it. It almost hit me like a brick, and I was, not long after that, I was gone.
Wow, it's kind of hit me like a brick. And if I may, I want to row back a little bit and make a few comments on some of the things that you've said, and then bring Cheryl in next to talk about vaccine injuries, COVID-19 vaccines, and the work that she's been doing with regards to the pregnancy monitoring data. So before I do that, I just want to say, oh my goodness, I've written down so many little notes here, but I wrote to the Royal College of General Practitioners and I asked them what the doctors knew about the serious adverse reactions and the ingredients of the COVID-19 vaccine. I received a reply back to say that doctors were not aware of the serious adverse reactions, nor were they aware of the ingredients. So I'm not surprised when you're telling me that you're not aware of the ingredients or serious adverse reactions of some of these drugs that you're giving. And one thing that just hit me, and this is just me talking as a mum, not as a nurse, but nifedipine is a labour blocker. Now, if somebody is in late stages of pregnancy, maybe 37, 38 weeks, and is exhibiting a high blood pressure, then I think back in my day, possibly we would have talked more about maybe we should get that mum delivered now, rather than give them something to reduce the blood pressure, but also to stop labour, because once baby's born, then everything normally goes back to normal fairly quickly. So that was one thing I wanted to point out. The other thing that I wanted to point out too was that in my day, and we have to remember that you've done a BSc in midwifery, whereas in my day we had state certified midwives. So student midwives were on the wards and on the prenatal, antenatal, postnatal, labour ward, in theatre. They were everywhere, and they were the heartbeat of the hospital. They literally did. You would have senior student midwives or senior student nurses. You would have them supervising the juniors, and the senior student nurses would be supervised by the staff nurse or the sister, and that's how it would work. And we would be on the ward all the time. And in my day also, and in Cheryl's day, we were told not even to take a paracetamol. You know, pregnant mums, fresh air, healthy food, early to bed. You don't need to take an, unless obviously you were diabetic or you had a medical condition that required long-term medication. But we were told generally not to take anything. But also there, Victoria, you were talking about busy wards, and I want to come back after Cheryl's talked about vaccines, because I want people to remember that you're not just dealing with mum. You're dealing with mum, you're dealing with baby, you're dealing with partner, husband, grandma, whoever has come to be with a support for mum, and you're dealing with students too. So labour ward is a very busy place to be, with a lot of people and a lot of emotion. So I just wanted to make that point, because it is a very intensive environment. Cheryl, can I bring you on to talk more about the vaccines, and especially the vaccines that we've been given, or that they've been given to pregnant women and also to babies?
I've got a leaflet here that the MHRA was asking maternity units, midwives, to give out to pregnant women, to ask them if they'd take part in the yellow card vaccine monitor, so that they had pregnant women involved, so that they could talk to them before perhaps they became pregnant, or what time they had the injection, the vaccine, in relation to their trimester and what have you. I don't know whether this is something that you have seen, whether it was something you were asked to give out in your hospital. Did you have anything to do with the yellow card vaccine monitor?
No, I didn't work in community, and I haven't worked in community for quite some time, since 2022 or 21, I think. I can't quite remember. I think it was 21, late 21. And I can imagine that will probably be in the women's packs. Because I work in an acute environment, it's literally what I see there and then. So no, I'd never seen that. And I've never given a vaccine. I've never given a COVID vaccine or a flu or a whooping cough, because I wasn't in those areas and I hadn't done the e-learning. In fact, I refused. It got sent to me, but I didn't do it.
Okay. Well, this actually states to women, the large trials which showed that these vaccines are safe and effective did not include pregnant women. So often happens in clinical trials. This means there is limited information about the effects of COVID-19 vaccination in pregnant women. It said a very small number of women became pregnant after they received the vaccine in a trial. There was 200 and more, and they weren't followed up. There was no sign of problems, but the numbers are too small to be certain. But in the end, the MHRA is collecting more information to help us build a better picture. So will you take part is basically what it was saying, having told you what they'd just told you. So that is the vaccine monitor. You were saying that most of the people who had problems seemed to be vaccinated. Did you find that most of the pregnant ladies who were coming into your labour wards had been vaccinated?
Yeah, so you would always do a check. From very anal person. I do everything methodical. So it'd be front to back book, and you'd always see that they'd have their whooping cough and their flu. It was very rare I ever met anybody that didn't, and I think at that time I trusted my governing body. I trusted my employer. I trusted that they would always look out for the safety of other people. So when they were coming in through triage, it's so busy, and I didn't do nights because I couldn't as a type 1 diabetic. So it's so busy in the day that it's just not possible to even sit and have a conversation with someone about anything like this. It's just not possible. So I wasn't aware of anybody that hadn't had the vaccine. If I asked them, they'd always say yes. Now, they might have not had it, but they didn't want an argument or anyone to judge them, because it can be quite judgy, can't it, in healthcare? And they probably just didn't want a discussion. So who knows by that point who did and who didn't, because they might have just said, yes, I did. But to be honest, through our time through COVID, it was absolutely drummed into us. This was the most alarming thing about it. A woman would attend on her own without her husband in labour, or in labour they could come in as one at one point, but that was it. But if they're on the ward labouring, and they might have been labouring for hours, they weren't allowed anybody. So it's interesting that they could be in a bed and have a mask on and the curtains shut and labour, and couldn't have a partner in, and we couldn't sit together at desks, and there was tape everywhere. But you have to remember, I was doing vaginal examinations all the time. I'm touching a woman. I'm touching an open cavity within her body. None of it ever really made sense. None of it was logic sense. So I think for me, I was never really aware that there were trials. I thought it was all tickety-boo. I trusted all of these governing bodies and all these peer reviews and all these evidence-based practices, that I would never have questioned it. I only questioned it when I started to see that I was giving out Labetalol like it was sweets. I felt like a drug nurse. And I know you used to get those, didn't you? Go around the wards and giving out drugs. It was just you're giving out drugs. I have actually tried to look the statistics of Labetalol figures, and they're not obtainable. So I need to go and do some research on that. But I felt like the biggest problem since the vaccines were hypertension, bleeding, antenatal bleeding, postnatal bleeding, and diabetes. We had so many women with diabetes. So there was just a lot going on with it, with the fact that it just couldn't all of a sudden just be COVID. A lot of these women were no longer COVID tested. They were no longer COVID positive. And many of them didn't have any long-term health conditions. They were normal, quite healthy women, other than these complications.
Victoria, I've kind of been counting up the number of vaccines that pregnant women are being asked to have, and it's whooping cough, tetanus, diphtheria, COVID, flu, RSV. It seems like crazy. It seems almost as though we've been talking about assisted dying for a very long time, the assisted dying bill on UK column, and it looks as though we've medicalised death, or death has become medicalised, and now birth has become medicalised, the most natural, beautiful process ever. But we're hearing all of these horror stories, and they are horror stories, and I know that you've got a ton more. But for people that are watching now, grandparents like me, and new mums, and people thinking about having a family in the future, this is all going to be very scary for them. And I'm already receiving emails from people that are cautious about going to the NHS. But I think we have to redress the balance a little bit and reassure women that if they're informed, take somebody with you that you trust, then things don't have to be horrific for you. What would your advice be, Victoria, for women that are watching this, for grandparents that are watching this, and they're due a new relative anytime soon, and they're scared? What would you say to them?
Fear is not pleasant. Mix that in with vulnerability in pregnancy. The unknown is a recipe for an outcome of worrying times for people, especially with mainstream media news, someone like me coming on and then saying all of these things, and lots of people have said, it's your duty to stand by your NHS, it was your duty to stand by your profession, but it doesn't feel right anymore. So I am acutely aware that we have to be really, really careful that we're not tipping this balance. We've gone from home birth being everything, but we had high rates of stillbirth back then and maternal loss. However, a lot of that was due to poor sanitation, big workhouses, overcrowded houses. So people moved into hospitals to birth if they didn't have good sanitation. And it wasn't too long until the 1960s that we see that, and 70s, that birth then became actually everybody had to birth in hospitals. So you robbed anybody of a choice then. and women went for it. And so since then, we've been really locked in a bit of a battle of trying to get these home births back out into the society. Now, like I've just said, one tip of one thing could be far, far worse. So we have to be very careful. So I am in support of free birth. I am in support of home birth. I am in support of hospital birth, and I'm in support of cesarean section. But where it has to come from is within the woman. It has to come from in her and from her heart space of what she wants. So what we have to be mindful here is about education through your own understanding. Our birth is our responsibility. And I know this is going to be a little bit uncomfortable, but actually I went around for the last 3-4 years and blamed the consultant for my care and blamed the consultant for my birth. When I came from a home birth the time before that, it wasn't her fault. It was my decision. I made the decision to have that birth because I didn't fully inform myself and heal myself enough to understand that this trauma was secondary to some primary issues that I was carrying. So what we have to do is we really have to go back into our heart space together as families in an environment where we can be understanding, compassionate, sharing stories, being really transparent about the true grit that being a mother's really tough and giving birth is really hard. And raising a child is equally really, really, really enormous. It's huge. What a responsibility. So I think for me now, it's about having a good balance, but it's got to come from the woman, and it's got to come from her. And then behind her is her partner, and behind her is her family of support. So when you go to a hospital and you're going in for your appointment, sit there with open arms and receive the information that you're hearing. And when you hear it, what you then want to do is you want to make sure it fits in your and lines with your values. Is this what I believe? Do I believe this? Or is this coming from a place of my fear? Once you feel that it's coming from your heart space, you will make a better decision. And I think we are forced to make decisions quickly because the NHS is running at 100 million miles an hour, but us in our lives aren't running as fast as that. So we get dragged into the NHS's energy of make the decision now because we haven't got time and we won't be able to see you again because we're busy. And I think women just need to get, oh, okay, doctor, thank you so much for your time, but I'm just going to go away and sit back. I'd like to book another appointment with you and I'd like to talk about this again. We haven't got enough reflection of what's going on. We haven't got enough awareness. And I think that's what's missing crucially is that women are no longer in control of their birth, their bodies. They're giving it over and they're losing the control, which is making them anxious, which is making fear-based decisions. So I think the answer to that, Debbie, is we've all got the responsibility to educate ourselves and make a decision with love of ourselves.
I definitely agree with that. And you know what, young ladies out there, partners, listen to your parents, listen to your grandparents, talk to the wise people in your family, which actually brings me on because I'm looking at the clock, Victoria, and I'm aware that we're coming up for time, but I just want to finish and tie this up on you, actually, and from nurse, mum and granny, and Cheryl, a mum as well, I want to ask you, this has been a very traumatic experience for you. This was your dream job, right? This was the job that you absolutely loved, and it's gone. And I want to know how you are, and are you receiving support?
Yes, I've got a really good family. I've got some amazing friends. And I think last year when when the trust obviously came back to me and said that, whistleblowers go missing overnight, I think that scared a lot of my colleagues around me too. But I've been part of a good group this year, been part of good people. I've stepped away from this. I stepped away for a few months to really heal myself and my triggers. So I've got great support. But obviously I know this is going to be quite a battle to try and see if we can make a shift in these changes. And it's not going to come from me. It doesn't even come from maternity. It comes from us at home on our sofa. From really teenage, if I want to think about having a baby, what does that look like? What does it look like in this world? So I think the support for me is now I'm feeling that I've made some small dent somewhere. And if it ends today and, my X gets shut down or whatever. I just think, well, I've changed or touched somebody's life somewhere, and that's all that really matters to me.
You've certainly changed and touched our lives, Victoria, and I know that we're probably going to have to hook up again, because I know that one thing that you are very interested in talking about, and we haven't got time, sadly, for today's interview, is mental health and pregnancy. So I hope very much that you'll agree to come back to it and talk to us more about mental health and pregnancy. But where can we find you, Victoria? Because lots of people are going to be saying, I want to speak to this lady. Where do I find her? So tell us, where are you?
I'm on X at the moment because it's the only platform that I'm not censored. I've put a couple of things on Instagram and it's been removed. So I think X is the place to find me. I don't always open and read messages if it's not your name. I know that people might not have their real name, but I find it difficult to open messages from people with no name and a blank face. I just need to know that somebody is authentic. But yeah, find me over there for really update stories, evidence, my own opinion, my exit interview, everything really. Yeah.
Well, I know that a lot of people are going to be doing that, and we will have the details of where to find Victoria in the article beneath this interview. And if you like what the UK column do and you think that the information is valuable, which we certainly do, please share it, please pass it around. Everybody needs to hear it. And with that in mind, before I throw to you, Victoria, for your last word, I just want to throw to Cheryl first for her last word. Cheryl, thank you so much for agreeing to join me and Victoria today. Your final thoughts?
Yeah, thank you. I would like to thank Vicky for being that whistleblower, being able to talk about her experience, because I think this is something that we all need to know about, because changes have to be made, because we're not only risking mums, we're risking the babies that they're producing. And it's a very special unit that she was on. And we need these services, especially if a lot of mums are having problems. So, yes, we need to keep speaking, and I'm sure we'll talk to Vicky again. Thank you.
And I'm really looking forward to it. But on that note, Vicky, I'm going to throw to you with grateful thanks and love for your last word.
Thank you both. So I want to put this out to women, and I'm going to call you and ask you to remind yourself that you are wise women. Our ancestors didn't have hospitals or drugs or interception. What they had were natural pharmacies. They were natural nurses, healers, midwives. They were all friends. They just bounced between communities and villages and door to door, and they would support each other, passing down knowledge of the real truth about bodies through touch and sound and feeling and sensing. And we've completely detached from that. Now we have to remember that back then, midwives and healers were the doctors that didn't have degrees. They didn't have exams and books. They were the people who were serving the people. And it was a keen interest for these people, and it would normally predominantly be women, but men and women were healers. And the inner wisdom that came from that is that we passed down for generations and generations how to birth and care for women and look after women. So I think my message to you now is to remember that there was a stage in all our lives that women, as wise women and healers, nurses, doulas, birth keepers, however you want to call them, there's a space for all of us in this solidarity. Everybody will benefit from an area of that, not just a restricted hospital service. And they're very highly regarded people. If anybody meets me and says, what do you do? And I say a midwife, I'm never met with, oh, I don't like midwives. It's very rare you find that unless there's been a very difficult situation. However, I just want you as wise women to nurture your inner being. I want you to nurture yourself and connect yourself and fully inform yourself about what it is you want for your birth, whilst taking into account the fact that we are in the situation we're in, and we do have hospitals and we do birth in them. So we can't run in any fear. We have to face it, and we have to try and find the best situation for everybody. because closing down any hospital or demising anything is not the answer. We have to just be very transparent in taking time to make our decisions. So what I say to all women who are wise women is to make the choice that you want to make, woman to woman. Call upon your mothers, your grandmothers, your sisters, and your friends, and talk about the birth that you want, and go and obtain the birth that you feel you need.